Thank you for joining this session of the HRSA Maternal and Child Health Bureau Emergency Medical Services for Children, Mental Behavioral Health across the EMSC landscape. My name is Lorah Ludwig. I am a public health analyst and federal project officer with the HRSA EMSC program, and I'm going to be the lead and moderator for this session today. The purpose of this session is to gain an understanding of the EMSC's program's role and current activities dedicated to improving care for children with mental behavioral health conditions. I'll return to this agenda later in the presentation, but I'll be providing just a brief background and context. We'll have speakers from across the landscape and the spectrum of EMSC programs, and we'll finish with a live question and answer session. The Emergency Medical Services for Children program. So our legislative mission, as many of us know, is to expand and improve emergency medical services for children and youth who need treatment for trauma or critical illness. So what I've wanted to do is really critically think and reflect on our mission and what it means against the current state and context for children with mental behavioral health concerns, particularly amidst increasing rates of mental behavioral health concerns in children and adolescents. The EMS system, as we know, has been serving an increasing role as a safety net for the mental health care system, and reflect on our legislative mission amidst the complex interplay of psychological and physical trauma. A bit of background. So approximately 1 in 5 youth experiences a mental disorder at some point during their lifetime. 1 in 10 youth will experience a serious emotional disorder, SED, that will significantly impact their ability to function at home, in school, or in the community. And suicide is the leading cause of death for children 10 to 14 years old and adolescents 15 to 19 years old. And all of this data in this slide is from prior to COVID-19. So as we know, as stated, the emergency care system is increasingly becoming the safety net for a fragmented mental health infrastructure in which children and adolescents are among the most vulnerable populations. From 2007 to 2016, pediatric ED visits for all mental health disorders rose 60%, and for deliberate self-harm, it increased 329% over that time period. The COVID-19 pandemic has had a negative impact on the mental behavioral health of children and adolescents. The CDC has found that the proportion of children's mental health related ED visits among all pediatric ED visits increased and remained elevated as compared to 2019. We know that this is happening amidst an ongoing nationwide shortage of mental health care providers, especially in rural and remote areas. And we know that there are inequities and resulting disparities in care and access and quality for race, ethnicity, gender, sexual orientation, and socioeconomic status. And so our role as the EMSC program is really understanding EMS and EMSC in the broader continuum of mental health crisis care. And so this image depicts aspects and partners in the continuum of crisis services, seeing that EMS and emergency medical services really play a vital role in the full continuum of care. And our work is to iteratively and continually try to work to understand the EMSC program and our role in improving care for children amidst the continuum of mental health crisis care. So as we reflect on EMSC and the broader continuum of crisis care services for mental health, we also need to reflect on the aspects and landscape of our program holistically. Our EMSC program, state partnership, the EIIC, the EMSC Data Center, Targeted Issues, PCARN, all work across these domains. So quality improvement, evidence generation, innovation, integration, and accountability to improve the infrastructure and systems of EMS care for children, working intersectionally, dynamically, iteratively, and collaboratively to comprehensively improve access and quality of pediatric care across the EMS continuum, ultimately improving outcomes for children. So as we reflect on the multifaceted dynamics of our comprehensive portfolio of the EMSC program, where do we fit as far as EMS care and mental health care for children? So this brings us back to the purpose of this session, which is to gain an understanding of the EMSC program's role and current activities dedicated to improving care for children with mental behavioral health conditions. I'm really excited to present our speakers for today, who are working across the EMSC program on projects dedicated to pediatric mental health and the EMS continuum. I want to emphasize the importance of lived experience grounding our work and informing and being a part of our research questions, project planning, and evaluation. So I'm grateful to present Mark Johnson, who served over 25 years as section chief in the Alaska Division of Public Health and retired as chief of community health and emergency medical services. Since then, for about 15 years, he has served as the Alaska EMS for Children Family Advisory Network representative and currently chairs the Alaska EMS for Children Advisory Committee. Today, he is telling a story about his family experiences with a suicidal adolescent. Next, we'll be hearing from Dr. Kate Remick and Dr. Mo Saidinejad. Kate Remick is an executive lead for the EMS for Children Innovation Improvement Center, and Dr. Mo Saidinejad is Director of Pediatric Emergency Medicine for the Department of Emergency Medicine at Ronald Reagan UCLA Medical Center and domain lead for the EIC Knowledge Management domain. And they'll be presenting on EIC activities in mental behavioral health. Following, we'll hear from Dr. Joyce Lee and Victoria Barnes. Victoria Barnes is a registered nurse and EMT from Connecticut. She is the third generation in her family to serve in the volunteer fire and EMS service. She has been a registered nurse at Yale New Haven Hospital for 14 years and currently works as a project manager on the EIIC state partnership team. And Dr. Joyce Lee is a pediatric emergency medicine physician at Boston Children's Hospital and an assistant professor in pediatric and emergency medicine at Harvard Medical School, who has devoted her career to enhancing pediatric emergency care in the general community ED setting. Dr. Joyce Lee and Victoria Barnes will present their work on creating a regional EMSC network and their current regional project, a behavioral health toolkit to help enhance the care of pediatric ED patient boarding for a behavioral health condition. Our last speaker will be Dr. Thomas Chun, who's the principal investigator for the San Francisco, Oakland, Providence, Atlanta Research Collaborative, or SPARC node, for PCARN, the Pediatric Emergency Care Applied Research Network. His primary focus is mental and behavioral health issues as they pertain to the ED from the research, clinical care, and public health perspectives. Dr. Chun will be discussing PCARN's past and current mental health work, including pre-hospital efforts. We'll finalize our session with a live question and answer. During the presentations, please feel welcome to type questions into the chat box, as these sessions have been pre-recorded, so we are able to answer live as the presentations continue. Thank you so much, and I look forward to presenting our speakers.
This is our personal story about needing crisis behavioral health services for a young teenage boy in a small city in Alaska. First, my wife and I got together in the early 1980s. We were both divorced at the time. She had two kids, a 14-year-old girl and an 8-year-old boy. I didn't have any kids at that time. And unfortunately, and the kids' father lived out of state, and they were visiting him about once a year. But when my stepdaughter was 13 and stepson was 11, their father killed himself by a firearm, which was very upsetting, of course, to my wife and the kids. And she ended up taking them down to that other state they weren't able to get there in time for the funeral, but they visited the grave to do their goodbyes and so on. And in retrospect, I think this was probably an adverse childhood event or experience for both of the kids. But as time grew longer, my stepson seemed to have been more affected by it than his sister. About 3 years later, when my stepson was 14, my wife got a call at work from the school, and they had evicted her son because of his disruptive behavior. So she left work to take him home. And when she got home, he was threatening suicide and actually had some plans, specific plans. So obviously she was very concerned about that and called me at work. I agreed to leave and come home immediately, but I asked her to call 911 so that, we could get assistance. And when I arrived home, the police were there, and we requested that they take my stepson to the hospital emergency department, which they did. At that time, our local hospital had very little resources to treat kids in crisis. So they determined that he had serious depression and suggested that we seek treatment at a facility in Washington State, which is over 900 air miles from where we live. So we spent a couple days checking with insurance and making arrangements, and then escorted him to Washington for it was a residential psychiatric treatment center for his treatment. Over the next 2.5 months, we flew down to Washington every other week to visit him on the weekends. And it was very stressful and very expensive. And initially, for the first couple months or so, he was extremely angry at us for having putting him in this facility. So that was very, very stressful. And during that time, we started reading books on mental illness and depression. And so my wife learned that she had been observing symptoms of depression in her ex-husband that she didn't realize at that time. After about 2.5 months, my stepson, he seemed to be getting better. He was doing pretty well in the school classes that they were offering at the facility. We were getting totally burned out trying to fly back and forth every couple of weeks. So we decided maybe it was time to bring him home. We talked to the psychiatrist and they said, well, they didn't think he was a danger to himself anymore, but he needed more treatment. And we just decided, at least if he's not a danger to himself, we should bring him home and hopefully work through some of his depression issues. He was discharged with a prescription for dysthymic disorder, which is a major form of depression. And initially, he seemed to be doing pretty well, but over time, his symptoms increasingly got worse. He struggled in high school. We had many meetings with administrators, counselors, and teachers. He eventually completed his diploma, but after he turned 18, he didn't want to take his medications anymore. Over decades since then, he has struggled with depression. He's had drug abuse, poor job history, criminal behaviors, including domestic violence. We have evidence he is a danger to us. We've had 2 long-term, 1-year domestic violence protective orders issued by the courts against him. To our knowledge, he has fathered 3 kids, but he's refused to meet his parental responsibility to any of them. We raised his oldest son from infancy with help from the boy's other maternal grandparents. The mother didn't want to be a mother to the child either. And so far, that boy that we raised is now 24 years old. He's doing pretty well, has a good job with the state, but he sometimes expresses resentment that neither of his parents wanted him. What we've learned from this experience is that mental illness can be a lifelong condition. And our society has not really provided adequate treatment resources for kids in crisis. So I look forward to hearing the presentations from mental health experts at this conference. on the approaches, new approaches for treating kids in crisis. And I also invite members of the audience who are interested in this topic to join our breakout session tomorrow with Bradley Gregg, who's the Chief Behavioral Health Officer at Bartlett Regional Hospital in Juneau, Alaska, who will talk about Juneau's response to a growing mental health crisis.
In the next few minutes, Dr. Kate Remick and I will talk to you a little bit about EIIC's activities centered around mental and behavioral health, including current content development, as well as upcoming collaboratives in mental and behavioral health. As you know, mental health is a very broad topic, and our first priority was to make sure that we come up with a concise way to develop content that focuses on the highest priority areas. We convened a group of multidisciplinary expertise, including psychology, psychiatry, emergency medicine, rural health, social work, as well as our partner organizations, to develop a strategy to identify the highest yielding topic areas within mental and behavioral health. Through a modified Delphi process, the group was able to narrow down the topics to suicide screening and managing agitated patient. I also like to point out that when we create content, our goal is not to just create content for clinicians, but we wanted to encompass the entire scientific community, including nurses and pre-hospital practitioners. And beyond the scientific community, we also wanted to create some content for patients and families, our advocates, as well as the EMSC stakeholders. Everything that we create, we wanted it to also have a specific element of equity, diversity, and inclusion. This is important because we're trying to reach a very broad audience of a diverse group of individuals, including those in the general EDs in the rural areas and low resource environments. So therefore, we wanted to make sure that our content integrated the concept of equity, diversity, and inclusion. And we were using the element within the Critical Crossroads toolkit that was created by HRSA, and several members of the team that developed that are also members of the team that helps us narrow down the content to suicide screening and managing agitated patients. We have a conceptual framework with which we work. It's called the knowledge to action cycle, which basically starts with identifying the problem, creating a strategy, testing it locally, getting feedback, then testing it more broadly, getting more feedback, and then disseminating it. Also creating a plan so that we can manage its sustainability by making sure content is periodically reviewed to ensure that it continues to be relevant and up to date. And right here, you see basically that process that includes evidence synthesis, which means a literature review that our team at Baylor conducts that looks at what's available out there and what is the current evidence. For mental and behavioral health, our two major areas of development were an algorithm that we're going to develop for managing an agitated patient, as well as a bottom line recommendation for suicide screening. We have several content that are being developed currently. As you can see in the bottom right, we are doing a podcast series of 2 on suicide screening elements, as well as what to do if somebody screens positive for suicidality. We're doing a learning module on agitated patient, as well as a verbal de-escalation video. If you wish to be involved in any of this, including reviewing content for us or helping develop content, you can just email us at the email that we have here, km@emscimprovement.center. We're always looking for more people to get involved. So you're more than welcome to email us and contact. This is basically an outline of our process. I just put that in there to show you that typically from inception to when our content gets launched, it takes about 6 to 9 months. For mental health, this is going to be launched later this summer, hopefully next month. Our content within our website is under an area called PEAK, the Pediatric Education and Advocacy Kit. And our PEAK area is going to be on the website. I'll talk about it in a minute or so. But before that, I wanted to also mention there's an area of our website that is not publicly available. That is the only area where you actually have to sign in and log in to register and be a person who's going to provide us with feedback. We're currently having about 680 or so individuals that have opted in to be reviewers for our content. Our content gets reviewed under this early access non-public area first, and then once it's ready for publication, it goes into the next area, which is called PEAK, and that's our deliverables. This is just a snapshot of what our peak pages look like. As you can see, the peak is organized by end user, the target clinician, nurses, families, etc. It also tells you what kind of a content it is, whether it's an interactive module or it's a simulation. Also tells you how long it is expected to complete that content. And you can also sort it in a variety of ways, like alphabetical. You can also submit your own content. There's a button here, as you can see, the right lower corner, that is asking you to submit content. We always are welcoming content. We'll review it and put the same process as we normally do and publish it in Peak if it is suitable for publication. So just to let you know, this mental health peak, as we discussed, is going to be slated for publication sometime next month by the end of the summer. We're very excited to do that. I will now pass this on to Dr. Remick to talk a little bit about the upcoming collaboratives.
Okay, thank you, Mo, so much. We're so excited about the Peak Toolkit and all the incredible information that's going to be available for others to use. As many of you know, our next step is really how do we integrate this actually into practice? And the EISC was created to more rapidly transform our healthcare system. And the way that we do that is through the underpinning of improvement science. So I wanted to take just a few minutes to talk about what improvement science is and how that's so helpful in being able to integrate this work into practice. As many of you know, the quality improvement methodology involves these rapid cycles of improvement, often called plan, do, study, act cycles. However, when most people receive initial information relative to best practices or new care pathways, they may not have a great understanding of how they actually implement that into their local system of care. So much of our work is to help them to initially gather a team of stakeholders together, work through the processes of care to identify opportunities where a change might be able to be improved upon, whether it's an element of efficiency or safety, elements of evidence base that really helps to inform outcomes, and then be able to shift that into practice through the development of new policies and procedures. Mental health is certainly a priority area of focus, and we're looking forward to offering a future quality improvement collaborative on this topic in particular. So just to spend a couple minutes talking about our quality improvement collaboratives, this is really an opportunity to bring together a multidisciplinary group of varied teams from diverse emergency department settings, where they can really work collaboratively to learn from each other about best practices, enablers, barriers, and how they overcame them. While many of our quality improvement collaboratives extend across the continuum involving both pre-hospital and hospital-based care, our focus for the mental health collaborative will be predominantly in the emergency department setting. What we will be doing is taking this evidence-based content, such as that's been found in the Critical Crossroads Toolkit and also in the Peak, and really integrating that into practice with the support of content experts who serve on essentially an advisory council to oversee the work that we're doing, hold us accountable, and help support the participants through rapid cycles of improvement. Our quality improvement collaboratives are really supported through a series of learning sessions, and it's during these learning sessions that there is an opportunity to really develop relationships or networking with other healthcare providers at various emergency departments or other settings, and really help to drive new opportunities and innovation into practice. All of our quality improvement collaboratives are data-driven, and it's really important that we have the underpinning and scaffolding to support them. So this includes not just the evidence-informed content or the improvement science, but we also have project managers to really support our quality improvement collaboratives. We have the help of IT infrastructure. Analytics are a critical component because they allow us to actually see when improvements are being made. But none of our quality improvement collaboratives would be successful without the support of our partners, AAP, ASAP, ENA, NASIMSO, and ACS, all of whom really help us to drive engagement and recruitment and to ensure that we really have a diverse group of stakeholders in each collaborative. But more importantly, that we also maintain the voice of our family advisory networks. As you all realize, and as you just heard, mental health is of utmost importance, mostly to these families and the patients that are experiencing them. I am really excited to announce that we will be offering an upcoming mental health collaborative. We hope to launch this in July of 2022, so we're still about a year out. We're finishing up the PEC Workforce Development Collaborative before we move into this. But our goal will be to make sure that every participating emergency department is ready to meet the needs of children with mental and behavioral health emergencies. We'll be using the Critical Crossroads Toolkit and the PEAK content to inform the work that these teams will undertake, with a focus on how to enhance their clinical care pathway to ensure that it has robust triage, screening, assessment, and disposition of these patients presenting with mental health and behavioral health emergencies. So with that, I'd just like to end just to be on the lookout for more information to come on the Mental Health Collaborative. We'll be sharing that through the Pulse and on our website. You'll hear about it through partners as well in recruitment. And if you have any questions relative to the PEAK content or even becoming a user to help provide feedback on other content that's being developed, please reach out to km@emscimprovement.center. That's the knowledge management domain at EIC. Thanks so much for your time.
Thanks so much for joining us today in our presentation, Stronger Together. We're going to be talking about our New England State Partnership to improve pediatric behavioral health. My name is Joyce Lee. I'm a pediatric emergency medicine doctor and assistant professor of pediatrics and emergency medicine at Boston Children's Hospital and chair of the New England PEC Network.
And good morning, I'm Victoria Barnes. I'm with the EMSC Innovation and Improvement Center. I'm one of the project managers on the state partnership domain, and I coordinate and some activities for the New England states, as well as other states across the US.
So our objectives in this presentation is to tell you a little bit more about the evolution of the New England EMSC Collaborative and PEC Network, the development of the New England Regional Behavioral Health Toolkit, and where we stand right now with our current toolkit and the future plans for that kit. So it really all began with Emery Petrak, who was the chair of the Massachusetts ACEP Pediatric Committee, who felt like there was a very low percentage of Massachusetts EDs with PECs. And so his goal was to increase the PECs to 100% in Massachusetts. And so he collaborated with a Massachusetts-based collaborative called MNET, who actually also does a variety of surveys called the NEDI, or the National Emergency Department Inventories, which you may have heard of. And so have many contacts with many EDs in the New England area. And these surveys really regard ED practices and workforce. And so in 2016, they started a grassroots outreach to increase PECs, which included reaching out to individual EDs. And by 2018, it actually increased from 30% to 100% of EDs in Massachusetts had at least one PEC. Given the success, there was a decision to expand this to the whole New England region. And so the approach was slightly different, but still grounded in a grassroots campaign. And so I oversaw that New England expansion, which included outreach to the state EMSC agencies, local ACEP, AAP, and ENA chapters for both endorsement and support. And then really started a grassroots campaign in collaboration with all of these entities. And so that grassroots campaign culminated in a combination of presentations at state meetings throughout the New England area, which includes Connecticut, Massachusetts, Maine, Rhode Island, Vermont, and New Hampshire. And then on top of that, I did individual outreach to ED directors and nursing managers, and MNET also helped with that portion as well. And so we were able to include a lot of different EDs throughout the New England region, and we're able to get over 80% of EDs in the New England region with at least one PEC. And then also as a part of this, and in discussing this with the EDs, we had said that we had identified that the biggest barrier that people were identifying was that they didn't know how they were going to support the PEC role within their ED. So a big part of this expansion was also talking about how do we create resources to support these potential PECs. And so we started first at the Massachusetts ACEP website had created a PEC resource website. We also created a listserv where all of the different PECs within the New England area can post questions to each other. And then I could also post any updates on educational resources, et cetera, available for the region. And then we also started talking about we should be creating projects together within this New England collaboration. And the first collaborative project that happened was actually all of the state EMSC agencies within our region came together to create an educational forum directed towards pediatric readiness and pediatric emergency care coordinators. It was originally supposed to be a live in-person forum, but unfortunately it was in March of 2020, which I think everybody knows what happened then. But we actually pivoted to a virtual forum that was very successful. So given our successful collaboration in recruiting PECs and then also with this forum, we really wanted to talk about regional projects that would support PECs. And so we thought about the different things that were happening within our region, and something we had heard individually from a lot of EDs was the mental health crisis among pediatric patients. And so you may be familiar with this in your own region, but certainly in our region, there were patients that are waiting up to 33 days, really weeks, to try to get an inpatient psychiatric bed. And a lot of EDs felt very ill-equipped for caring for these patients. So we performed a needs assessment with two aims. One was to explore the care to pediatric patients with a behavioral health condition in both urban and non-urban emergency departments, and also to understand the resources needed to optimize care for this population. So we used a qualitative approach using purposeful sampling to make sure that we were really talking to PECs from both urban and non-urban areas with differing pediatric volumes. So I'm not going to go into full detail about everything that we found, but in general, we found 4 different types of resources: patient resources, parent resources, ED staff resources, and ED administrative resources. Essentially, really what these EDs have reflected to us is that they felt like they were very ill prepared for this population, that they had not received any training in it, and that just in general, their EDs had little to no resources for this patient population. So the next step was to do a follow-up survey to rank the different resources needed. So from that grid that I just showed you, we basically sent out all of the things that people had asked for, and then asked the PECs in our region what were the top 5 things that they would want. And from their responses, we came up with this plan for our toolkit, which was videos about approach to pediatric behavioral health conditions because people felt like they didn't have enough training. A self-care activity binder, which includes things like basically a no-cost binder with activities that are safe to do for children, and also include things that can help with de-escalation. An actual agitation and de-escalation guide, which is in process right now. And then something that we're calling the comprehensive care plan. And what's in this is basically really nursing-driven tools to help them care and ensure safety for their patients, which include things like a daily activity living and medication tracking sheet for tracking, like when was the last time they showered, when's the last time they ate, a template schedule, behavioral health huddles with structured handoffs on how to specifically hand off this type of patient between shifts, and then a customizable patient-specific coping tool that would include things what for this particular patient works best to make them de-escalate and to help them cope with stress. So each resource packet is formatted in the same way. Each packet assumes that only ED nurses and ED physicians are going to be available, and that there will not be any access to child life, pediatricians, child psychiatry, or behavioral response teams. And the resources are designed to maximize user friendliness and to include resources to help with dissemination. So for example, the activity binder included a poster that people could print out and post along in their ED, and an introductory email that they could use to help introduce it to their staff as well. So for this next part, I'm going to pass it along to Vicki.
Thank you, Joyce. So one way we wanted to get the resources out to not only our state EMSC program managers, but to the various community hospitals throughout the New England region was to develop a website. And this website is open access. There's no account or password needed. Any EMSC website, EIIC has the ability to host. So if anyone is interested in hosting a website for their state or programs, just reach out to me and let me know. But basically the website is going to be a presentation of pediatric resources. The New England EMSC Pediatric Forum is on there that Joyce referred to earlier, and we posted our behavioral toolkit on here. And Joyce is going to pull up the website so we can just quickly show you a couple of the resources that we have available.
And so, yeah, so this is our website. So this is the New England Regional Behavioral Health Toolkit. And right now we just have one, which is the activity resource packet that I had mentioned. And as you can see here, there's an introductory video, and then the resource vendor I mentioned. There's also how to introduce it to your staff, and then a purchasing guide.
Okay, and the website is a work in progress. So as we add activities, as we add videos, things will be posted to the website as well. And another thing that we wanted to do, we didn't want to just hand over a binder and say, have a nice day. We wanted to get some training out there to our community EDs, to nurses and doctors who are interested in implementing some of the programming and also some of the activities that are in the binder. So we've decided to use a program called Project ECHO, which is based out of the University of New Mexico at Albuquerque. And ECHO stands for the Extension of Community Health Outcomes. And Yale University will be acting as what's called a hub, and each participating hospital will be a spoke. And this is a true all teach, all learn model. So our targeted recruitment at this point is to each New England state. We're trying to get 4 hospitals from each state to participate. And we really want people who have an interest in some quality improvement with their behavioral health patients, but also that are willing to try to implement this and collect some data for us as we go forward. So as part of the Project ECHO, we have a curriculum set, but we will do a needs assessment with our participants to see where they're at, where they need more help, where they feel they need more support. We'll also do some pre and post knowledge assessments as part of this. And the sessions will be monthly. It's going to be a 1-hour virtual session. Each session will feature a moderator and a content expert. The content expert will present for about 10 or 15 minutes, and then this will be followed by real cases that our participating EDs will submit, things that have actually happened in their ED, challenges they've come across. And then that will be followed by a question and answer period where we really get to this bi-directional learning. This is where hospitals explain some of their challenges, they share their successes, and everyone really has a chance to learn from each other. So some of our lessons learned so far. Start small and expand. So as we said, we're going to have 4 hospitals from each state. When you do a program like Project ECHO, about 24 participants is what they call the sweet spot. So we're hoping to expand on this programming as we go forward, but being that this is just our pilot, we're going to start a little small. We're going to continue to look for partners that have similar interests in the behavioral health field and in pediatrics in general. And also how best to serve our boarders in the hospitals, because this really is truly becoming a crisis in our EDs. Our outreach to the participants is really grassroots. We really want to understand the needs of our doctors and nurses out in the community ERs. We want to be sure we're hitting on those rather than just going along with our own agenda. And we want to have a good understanding what the EDs already have, what they don't have, what they feel they can implement, so we're not reinventing the wheel. And also continue to support and perform assessments for our next steps going forward.
Thanks so much for joining us, and feel free to reach out if you have any questions. We'd love to hear from you.
Yes, definitely. Please reach out, and thank you.
Good morning, everyone. I'm Tom Chun. I'm a pediatric emergency medicine physician at Brown University and one of the PCAR nodal PIs. I'd like to thank Lorah Ludwig for inviting me to give this presentation. Today, I'll be talking about behavioral health emergencies and PCARN, the work that we've done in the past, the work we're doing currently, and what we see in the future. As we all know, for the last decade and a half, mental health emergencies have been skyrocketing, overcrowding ERs and leading to horrible conditions such as boarding. You and EMS have experienced the same thing. In the pandemic, the results are a little mixed, but there have been both places where mental health calls have gone down, but also places where mental health calls have gotten very high. And unfortunately, like so many other things, there's pretty good evidence that there's significant disparities in mental health emergencies in the United States. So starting with PCARN, very shortly after PCARN was formed, one of the things that the network did was to look at what were their priorities for multi-center research. And this is the paper that Steve Miller wrote. And as you can see, the network rated mental health emergencies as the 7th most important topic. And this was in the early 2000s. And when you compare it to other rating systems, you see that mental health wasn't even on some people's radar. And this was, again, 10, 15 years ago. One of the first papers that PCARN published was the paper on the left. It was written by Prashant Mahajan, who's at University of Michigan. And using the PCARN core data project, taking data from that, they looked at the epidemiology of mental health related visits in PCARN emergency departments. And shortly after that, Jackie Grupp-Phelan, the paper on the right, who was at the University of Cincinnati at the time and is now at UCSF, did a study looking at the resources and epidemiology of mental health related emergencies. And what they found, not surprisingly, was that that mental health emergencies are a significant amount of our ER volume and require significant resources. Moving to some funded studies that PCARN has done. So this was the first study, which we were fortunate here at Brown to lead. Two pictures are my colleagues Jim Lanakis, who's a pediatric emergency medicine physician, and Tony Spirito, who's a child psychologist, looking at the National Institute of Alcohol Abuse and Alcoholism two-question screen. So it's a two-question screen that they had empirically developed, and they were looking to validate to see, was it a valid screen? And they also did something interesting with the screen, which was, do these two questions predict other high-risk adolescent behaviors? The two questions revolve around, basically, the questions are worded slightly differently depending on the adolescent's age. But basically, do you drink and do your friends drink? And those two simple questions, as it turns out, are very good at actually identifying kids who are at high risk for alcohol abuse. And it turns out also other high-risk adolescent behaviors. And I think what was really interesting about this study, one of the things I'll point out is that, as we all know, in the ED and in EMS, we're really busy. We have incredible pressures on our time. And one of the challenges of this work is being efficient. And this, I think, study points out that you can actually efficiently and quickly screen for alcohol use and other adolescent risk behaviors. This study was done in 16 PCARN EDs and enrolled 5,000 patients. And I'm happy to say, finished enrollment early. This next study was funded by NIMH, the National Institute of Mental Health. Cheryl King at the University of Michigan, Jackie Grupp-Phelan, who's now at UCSF, and David Brent at Pittsburgh were the co-PIs in this study. And I want to point out a couple things about this study. They had several goals. So one of them was, can you come up with a better way to screen for suicide in kids in the ED? But I think one of the really, really neat things about the study was that it wasn't just risk for suicide, but actually can you predict who will then go on to attempt suicide? To me, that's all suicidal ideation is important. I think what we most want to know is who's at higher risk, who are the ones that are going to attempt. And that's what I thought was so cool about this study. Another really cool aspect of it was that they used computerized adaptive screening, which is based on item response theory. And it's the idea that you ask a series of questions. Each succeeding question depends on how you answer the preceding question, and you actually get to your answer faster and more accurately. And the study enrolled 6,500 patients in the initial, in the derivation set, and over 3,000 kids in the validation set. And it looks like they do, in fact, have a valid screen that can very quickly and rapidly and efficiently screen for suicide. So let me turn to some things that we are working on right now. Spark is one of the PCARN nodes, and Nick Glom and Carl Spohr are the EMS affiliates in the Spark node. They're actually working on several different topics. This first study is based on the work that Carl and his colleague Tarek Trivedi did in adults in Alameda County. And what they are doing is they're retrospectively looking at EMS transports of kids with mental health emergencies with and without involuntary holds. And could they be directly diverted from the field to their behavioral health center and bypass the ED? They use probabilistic matching to identify unique patients, clinical and demographic characteristics. Then they also looked at the proportion who met the EMS field criteria for diversion. And they evaluated, was it safe? Those kids that were taken directly to the behavioral health center, how often did they get retriaged back to the ED within the first 12 hours of being transported? So in their 5-year data set, there were almost 38,000 pediatric EMS encounters. Behavioral emergencies were accounted for 21% of those calls, which was the second most common call, only behind trauma. Of those kids, almost 3,000, about 37% met diversion criteria, so they were directly transported to the behavioral health center. And of those, very few, only 13 patients, less than half of 1%, wound up needing to go from the behavioral health center to the ED, and none of them required critical EMS or ED interventions. So in summary, it looks like pediatric behavioral health patients in Alameda County can be safely diverted to a behavioral health center using EMS field protocols. The second thing that they're looking at is potential disparities in restraint use by EMS for pediatric behavioral health emergencies. So they're retrospectively looking at both physical and chemical restraints used by ALCO, Alameda County EMS. They're looking at the socioeconomic and demographic factors that may impact the use of these restraints. They're linking this data to data from their regional children's hospital and the behavioral health center. And they're going to use applied area deprivation index to identify neighborhood-based factors that may predict these disparities. Stay tuned, they're working on it right now. A third study that they are doing is to look at the behavioral health resources that are available to EMS. So they are surveying EMS and PCARN affiliated hospitals to look at what resources the EDs and the EMS agencies have available to them. They're looking at patient access to behavioral health and services and inpatient care. They'll be investigating gaps in clinical care and opportunities for improvement. And they're also looking at existing EMS diversion protocols like the one I just talked about. And lastly, they're looking at the Alameda County CAT team, which is the Community Assessment and Transport Team, which combines crisis transport staffing model and technological support. So the response team is a mental health provider teamed paired with an EMT. Their goal is to increase crisis services and timely system improvements to patients and to the EMS system. They'd like to increase assessment accuracy, meaning specifically correctly identifying who can be transported, who doesn't need transported, who can be transported directly to the behavioral health center. And I think we all know that, or all agree that they're trying to decrease the use of law enforcement and EMS resources, not to decrease services, but just to improve efficiency. So they'll be doing in the field mental and physical health assessments, transporting as necessary, and looking at, do these EMS mental health teams connect clients to a wider array of services in real time? So what are opportunities for the future? As we just talked about, embedding mental health workers, as you've seen in the news, is all over the news and sounds very, very promising. And that's something that I think PCARN would be very interested in working on. And telehealth, both for EMS in the ED, especially for resource poor areas. If you don't have readily available mental health services, will telehealth be the way to improve the care for these kids? And lastly, to follow up on the studies I mentioned, the ASSESS study and ED STARS studies, those to us are the next natural studies of how can we improve the care of those kids with suicide and how can we continue to improve the efficiency of screening for those conditions. Thanks for your attention, and I look forward to the panel discussion.
Thank you so much to our presenters for giving us a comprehensive analysis and discussion of mental behavioral health across the EMSC landscape. Looking at the chat box, it looks like there's been some great comments and overwhelming appreciation for Mark's story and lived experience. A lot of excitement for the upcoming behavioral health collaboratives. And it looks like we have a few questions that I want to make sure we get to. So my first question for Kate is, what is your process for identifying and inviting stakeholders into your QI process?
Thanks for that. Thanks for that question. So we usually will recruit stakeholders through all of our entire EMSC communities. So oftentimes reaching out to our EMSC state partnership managers. We also reach out through our national partnering organizations and professional societies, be that the American Academy of Pediatrics, American College of Emergency Physicians, Emergency Nurses Association, American College of Surgeons, and NISMSO. So we will work through a similar process to what we have used in the past in order to include as many individuals and or hospitals that are interested and ensure a great diversity there. Hopefully that answers the question. Thanks.
Thank you, Kate. Another question or multiple questions around Project ECHO. Will Project ECHO be available to anyone that wants to register?
All of our entire EMSC communities. So oftentimes reaching out to our EMSC state partnership managers. We also reach out.
Hi, Laura. I think that question is probably for me, but I don't know if there was a different question underway for the New England region, but if other areas are interested in kind of replicating it or talking more about the content, that's Vicki and I, and we'd be happy to talk, see how we can collaborate or see about to host their own echoes and talk more and we can talk one-on-one with people about how the ECHO project works. We will probably be having future ECHO sessions as well, and those are things that we can.
Thank you, Joyce, and I'm sorry I'm having a little bit of broadband issues. I hope that's not transferring out to the group, but bear with us. Hope I'm coming through. And thank you, Joyce, for picking up on that. Another question that I saw in the chat. Let's see. I believe this is for Tom. It could be. I believe that's when it came through. There's a bit of a delay. Are they looking at insurance reimbursement for EMS agencies transporting to a mental health facility versus an emergency room, similar to challenges EMS faces with community medicine?
Yeah, thank you, Lisa and Carolina, for your question. And Patricia also put in a question about law enforcement. Terrific questions. I am not the expert, so I'm going to need to look into this with Nick and his team, and I will get back to them individually. But really important issues and really great questions.
See some really great, so I'm trying to catch up with all the activity in the chat box. I see some really great discussion. Have you all noticed that boys seem to have a harder time continuing on medication once they hit adolescence or young adulthood? All of my nephews stopped at that age when they were that age. Any studies looking at that? Does anyone speak to that on the call? Well, thank you for that comment, Patty. So I guess I want to just really thank all of our speakers for their time and expertise today, relaying a comprehensive framework of how the EMSC program is addressing mental behavioral health concerns across the child and adolescent population. I really want to emphasize, our work being grounded in lived experience, and appreciate so much Mark Johnson's story that he shared and the vulnerability in that. And so that we're centered around kind of that core mission of improving care for these children. And so I want to ask the group of panelists that we have, how can we continue to keep and integrate lived experience at the center of our work, informing our programs, our research questions, the way we evaluate, and onwards. I wanted to know if any of the panelists have any thoughts on that.
I think just sharing the personal stories like Mark did just brings us to life, if the crisis in the EDs hasn't already. So I think just making people feel a little more comfortable in sharing their stories. Mental health isn't always the easiest thing to talk about, but letting everybody know this is a safe environment to do so, because it'll really help us learn from each other.
I just offer the sort of obvious answer that the key is to stay patient-centered. They're the ones who are living it. They're the ones who know what they need. And I just think it's so important that we remain patient-centered.
And the thing I was going to add is that I know that going forward with we're integrating as a part of our processes for everything is talking to ED staff, talking to parents, and with developing our tools. And we also have lots of plan up with parents and with ED staff to really understand kind of where we can still expand things and still help things where
I'll also add that, mental health is a moving target. The prevalence of mental health among children continues to increase, but also the scope of it continues to change. So it's important to be flexible and continue to learn, because what you learned yesterday may not be applicable tomorrow. So we're continuing to learn and increase our knowledge in this field.
Well, thank you all so much. Thank you to our presenters for excellent presentations today. Thank you to our audience for tuning in. I want to give some directions for our next step. So we have some breakouts from 2:30 to 3:20. Breakout 1 will be EMSC communications. Breakout 2 will be pediatric recognition programs. And then breakout 4 will be the role of state partnership programs in regional disaster exercises and drills. So you can make your way to take some time. We have about 3 minutes between now and then to make your way to the Zoom breakouts. I just want to emphasize my gratitude to our presenters today. Thank you so much, and thank you all for joining us for this mental behavioral health session across the EMSC landscape. Thank you.